Welcome back to the deep dive. Today, we're not just looking at another organ system, we're diving into the body's ultimate external chemical clock and its protection system, the skin.
We're tearing down Chapter 15 of one of the foundational histology texts, taking everything you need to know about the integumentary system, its structure, its specialized cells, its weird biology.
And giving it to you in one comprehensive, high-impact breakdown.
Our mission today is to provide you with a full, structured understanding of the largest organ you possess. We're going beyond just the basic biology.
All right.
We're exploring the incredible molecular and cellular decisions the skin makes every second, from how it keeps water in, how it defends against UV light, and even, how it decides when to shed its own cells.
So if you need to master the microscopic details of your exterior, this deep dive is your shortcut.
Let's get into it.
Okay, let's start with the shear scale. When we talk about the integument, we are talking about a massive organ.
It's huge. It covers approximately 1.8 square meters of surface area, and depending on who you are, it makes up a staggering 15 to 20% of your total body mass.
That is a substantial piece of biological real estate.
It truly is. And when we use the term integumentary system, we're referring to the skin itself, what clinicians call the cutis, or integument, alongside all its accessory structures.
So it's more than just the skin.
Much more. Structurally, we organize the system into three main distinct layers, each with its own specific role and its own embryonic origin.
First up, the most superficial layer, the one we interact with the world through, the epidermis.
The epidermis is derived from the ectoderm, so the outer layer of the embryo. Histologically, it's defined as a keratinized, stratified squamous epithelium.
That's a mouthful. Let's break that down.
Well, what's crucial to understand here is that the epidermis is in a state of constant dynamic change. It grows continuously from the bottom up.
But it stays the same thickness.
Exactly. It maintains its normal thickness through the continuous shedding of surface cells, a process called desquamation. It's perpetually renewing itself while staying exactly the right size.
Okay, so below that, providing the scaffolding and resilience, is the dermis.
The dermis is the mesoderm-derived layer. It's robust, composed primarily of dense, irregular connective tissue.
So this is the tough part.
This is the tough part. When you talk about the skin's mechanical strength, its ability to stretch and withstand tension, you were talking about the dermis. This layer dictates the overall thickness and durability of the entire skin organ.
And then anchoring everything, serving as padding and insulation, is the third layer, the hypodermis.
The hypodermis is technically the layer deep to the dermis, equivalent to the subcutaneous fascia. It is essentially loose connective tissue holding variable amounts of adipose tissue.
A fat tissue.
Right, fat tissue. It's arranged in distinct lobules separated by connective tissue septa. Functionally, this is key for energy storage and insulation.
So people in colder climates might have more of this.
That's what the text notes, yes. Individuals in extremely cold climates, or those who are well-nourished, tend to have a thicker hypodermis for increased thermal regulation.
The system isn't just these three sheets. It also includes specialized factories embedded within them, the epidermal derivatives, or appendages. What structures are included in this list?
These are structures that develop from the epidermis but extend down into the dermis or even the hypodermis.
Like what?
They include the hair follicles and the hair they produce, the nails, the complex eccrine and apocrine sweat, sudoriferous glands, the oil-producing sebaceous glands, and functionally, the mammary glands.
All critical for survival and communication.
Absolutely.
That brings us to the major functions of the skin. It's astonishing how many major physiological tasks the skin performs simultaneously. Let's walk through the 6 primary roles outlined in the source.
First, the function everyone knows, but which is remarkably complex, the barrier function.
And it's not just one barrier.
Not at all. It's 5 barriers working together. It's a mechanical barrier against trauma, a permeability barrier against uncontrolled water loss, a chemical barrier against toxins, a biological barrier against pathogens, and of course a UV barrier due to pigmentation.
Second, the immune connection, the immunologic function.
The skin is constantly interacting with the immune system. It acts as an active immunological sensor, containing specialized cells that are highly capable of antigen processing.
So they're like the scouts.
They are. They relay crucial information about the external environment to the rest of the body's adaptive immune system.
Third, and perhaps the most vital for minute-to-minute survival, is homeostasis.
This role is primarily centered on thermoregulation, regulating body temperature via sweating and adjusting blood flow, and, critically, controlling water loss to maintain the body's internal fluid balance.
Fourth, The skin is an incredible sensor array, sensory information.
The entire system is densely innervated. It is how we sense and convey information about touch, pressure, heat, cold, and pain back to the central nervous system, allowing us to react instantly to external stimuli.
Fifth is a function often forgotten when you think of the skin, one associated usually with the endocrine organs, endocrine functions.
That's right. The skin is not just passive. It secretes various local hormones, cytokines, and growth factors.
But the big one is vitamin D.
The big one is vitamin D. Its most famous endocrine role is the synthesis of vitamin D3. It converts precursor molecules into this hormonally active vitamin, which is absolutely essential for regulating calcium metabolism throughout the body.
And finally, sixth, a simple but important housekeeping job, excretion.
Yep. Via the exocrine secretion of sweat and sebaceous glands, the skin helps eliminate small amounts of metabolic waste products, including urea, salts, and various organic compounds.
Speaking of things moving through the skin, the text highlights a great clinical application. Absorption. We spend all this time detailing the skin's barrier function, yet we exploit its ability to absorb substances therapeutically.
Well, the barrier is excellent against water-soluble substances, but it's less effective against certain lipid-soluble compounds.
And we take advantage of that.
We do. This permeability is leveraged in transdermal delivery systems.
Yeah.
When you use nicotine patches, hormone replacement gels, or anti-nausea medication patches, you are exploiting the skin's ability to allow these lipid-soluble agents to pass through the epidermal barrier and enter the dermal vasculature.
Providing a constant systemic dose.
Exactly.
Before we get into the layers, let's clear up a classic histological ambiguity. Thick skin versus thin skin. This is often confusing because the terms don't always align with the skin's anatomical thickness.
This is a critical nuance. When a histologist refers to thick skin or thin skin, they are referring only to the thickness of the epidermal layer.
Only the epidermis.
Only the epidermis. This distinction has nothing to do with whether the dermis or hypodermis is thick or thin.
So where do we find the histologically defined thick skin?
Exclusively on the palms of your hands and the soles of your feet. These areas are hairless and are subject to maximum abrasion.
Right.
They have an extremely thick stratum corneum, the outermost protective layer, which is the defining feature of thick skin.
And thin skin.
Thin skin covers the vast majority of the body. It possesses a much thinner epidermis and contains hair follicles almost everywhere.
And this is where the confusion comes in?
Right, the classic anatomical misnomer. The skin on your upper back, for example, can be the thickest overall skin on your body because of a massive dermis. But its epidermis is still classified histologically as thin when compared to the sole of the foot.
It's all about the epidermis.
It's all about the epidermis.
And we launch into the epidermis proper. This is where the core machinery of protection happens. It's a stratified, squamous epithelium organized into distinct layers or strata.
Right. And we need to describe them from the bottom where life begins to the top where life ends.
So let's start with the foundation, the deepest layer.
That's the stratum basal, also known as the stratum germinativum.
Why germinativum?
Because this is the powerhouse of generation. It's a single layer of small, cuboidal to low columnar cells that rest directly on the basal lamina.
And this is where the stem cells are.
This is where the stem cells are, the keratinocyte precursors, that undergo constant mitotic division to replenish all the layers above.
So if you look at this layer in a micrograph, what would you see?
The nuclei stain, intensely dark, a feature known as basophilia, because these cells are packed with DNA and free ribosomes, ready to synthesize new proteins and divide rapidly.
And they're anchored down.
Very strongly.
Yeah.
They're anchored. Often called the spinous or prickle cell layer. These cells are much larger, and the layer is several cells thick.
And the name, spinosum.
It comes from the numerous cytoplasmic spinous processes that project toward adjacent cells. The spine is actually the visible junction point, the desmosome.
So what's happening to make them look like that?
In histological preparation, the cells shrink, pulling away from each other, but the desmosomes hold firm, making the cell connections look like tiny spikes or prickles, hence the term prickle cell.
So those prickles provide strength.
Essential mechanical grip. It allows the epidermis to resist shearing forces.
Then the cells transition dramatically in the stratum granulosum.
This is a thin, pivotal layer, only 1 to 3 cells thick, and it represents the most superficial layer where the cells are still non-keratinized and nucleated.
What's its defining feature?
Its defining feature is the accumulation of conspicuous, large, irregularly shaped, and intensely basophilic keratohyalin granules.
And what's inside those granules?
They contain crucial proteins. Specifically, they're precursors to filaggrin.
Filaggrin, what does that do?
Filaggrin is the protein responsible for aggregating the keratin intermediate filaments, essentially gluing them together into the dense, thick bundles known as tunifibrils.
So it's the prep step for becoming hard keratin.
That's the immediate pre-step, yes.
Okay, now in thick skin, we see an intermediate layer, the stratum lucidum.
This layer is found only in the palms and soles. It appears highly refractile and stains strongly pink or eosinophilic in a light micrograph.
What's happening in this zone?
This is a zone where keratinization is in full swing. The cells are flat, they're nuclei, and most cytoplasmic organelles have completely disappeared. And they are essentially translucent, fully packed with pre-keratin material.
And finally, the very surface, the protective sheath, the stratum corneum.
This is the outermost layer composed of flattened, desiccated, and enucleate cells. These are the terminally differentiated cells filled almost entirely with soft keratin.
And its thickness must vary.
It varies greatly. It provides significant mechanical protection in thick skin and calluses. And critically, these cells are waterproofed externally by an extracellular coating of lipids, which we will detail shortly.
It sounds like the entire life cycle of a keratinocyte is a one-way trip, culminating in a specific form of death. The text calls this terminal differentiation as specialized apoptosis.
That's a fascinating concept. The journey involves nuclear fragmentation, which is typical of apoptosis, beginning in the stratum granulosum.
But it's different from normal apoptosis.
It is, because it avoids the cellular fragmentation seen in normal programmed cell death. Instead, the cell is preserved, filled with keratin, and then eventually sloughed off. It is an orderly, controlled, and necessary death for barrier formation.
Let's talk about the speed of this replacement, the epidermal turnover rate. How long does the entire cycle take?
To maintain the equilibrium, the whole journey from a basal layer stem cell to a desquamated surface cell takes approximately 47 days.
Wow.
And it's paced meticulously. About 31 days are spent traversing the spinosum and granulosum layers, and then about 14 days are spent sitting in the stratum corneum before exfoliation occurs.
That journey must be perfectly timed, especially the final step of letting go. So how exactly is the regulation of desquamation managed? It can't just be random or the skin would fall off sporadically.
You've hit on the critical insight. This is managed by an incredibly precise, pH-dependent proteolytic control system.
Okay.
The bonds holding the cells together, the desmosomes, are cleaved by enzymes called kallikrein-related serine peptidases, or KLKs.
But if those enzymes are present, why aren't the cells cleaving immediately in the lower layers?
Because of a physiological inhibitor called lectii, that's lymphoepithelial Kazal type inhibitor.
I see.
In the granular layer, the skin's pH is near neutral, which strongly binds lectii to the KLKs, keeping them inactive. But here's the elegant part. As the cells move up, cellular pumps change the environment, and the pH acidifies significantly, dropping to between 4.5 and 6.0 near the surface.
So the pH gradient acts as the biochemical trigger for shedding.
Precisely. That drop in pH causes lectii to dissociate, activating the KLKs. Once active, the KLKs immediately start degrading the desmosomal proteins, leading to controlled, necessary exfoliation.
It's a remarkable example of chemistry dictating cellular timing.
It really is.
And that mechanism explains why failure in this system leads to specific disorders, like psoriasis.
Psoriasis is a classic hyperproliferative disease where that turnover rate goes haywire. Instead of 47 days, the epidermal turnover is drastically accelerated, sometimes taking only 8 to 10 days.
What does that do to the skin?
This breakneck speed means the cells don't fully differentiate or keratinize properly, leading to the characteristic scaling and plaque formation due to a thickened, abnormal epidermis.
And if the inhibitor protein itself is defective, we see a rare but severe disease like Netherton syndrome.
Yes, Netherton syndrome is caused by a genetic mutation in the SPINK-NK5 gene, which codes for LexII. Without functional lectii to inhibit the KLKs, desmosomal cleavage occurs prematurely and excessively.
And the result is a bad barrier.
A chronically impaired barrier function and generalized scaling across the body. It really underlines just how important that single inhibitor is for the mechanical integrity of the skin.
Let's focus on the primary cell, the keratinocyte. We know it produces keratin, but its second major role, forming the epidermal water barrier, is the reason we can survive on dry land.
This barrier is absolutely essential for terrestrial life, maintaining body homeostasis by preventing fatal fluid loss.
And it's not one thing.
No, it's not one component, but two integrated structures, primarily established as the keratinocytes undergo terminal differentiation.
What is the first component, the mechanical part?
That is the cell envelope, CE. Think of it as an insoluble protein-based shell, about 15 nanometers thick, deposited on the inner surface of the cell's plasma membrane.
What's it made of?
The primary component here, accounting for over 80% of the mass, is the protein loricrin. This shell provides the cell with immense mechanical stability and thickness, especially in areas of high stress like the palms and soles.
And the second component, the waterproof seal, comes from a unique organelle.
That's the lamellar body, often called membrane-coating granules. These are synthesized within the keratinocytes starting in the stratum spinosum,
And they're packed with lipids.
packed with various lipids, most crucially ceramides and phospholipids.
And what happens when they reach the granular layer?
They are secreted via exocytosis into the narrow intercellular space between the granular layer and the stratum corneum. These lipids organize themselves into the lipid envelope, a 5-nanometer thick layer that attaches to the cell surface.
And that's the waterproofing.
That is the waterproofing. Key among these lipids is acylglucosylceramide, which gives the surface a highly water-repellent, almost Teflon-like coating.
So mechanically, you have the loricrin-based protein envelope protecting the cell, and chemically, you have the ceramide-based lipid envelope waterproofing the space between cells.
Exactly. And just briefly note that ceramides are also potent signaling molecules in the skin involved in regulating cell differentiation and apoptosis. They do double duty.
The text provides a chilling functional implication of this barrier. When it fails on a large scale, the homeostatic failure is immediate.
We see this in severe burn patients. When the epidermis is destroyed over a large area, the barrier is compromised, leading to immediate, massive, and life-threatening fluid loss.
A stark reminder.
The constant battle the skin fights every day to maintain this barrier is truly a matter of life and death.
Now we introduce the key non-keratinocytes that give the epidermis its intelligence and defensive capabilities. Let's begin with the skin's natural sunscreen, melanocytes.
Melanocytes are the dendritic, neural crest-derived cells, typically making up about 5% of the epidermal population, located in the stratum basal.
And they work in teams, right?
They do. They don't attach to the keratinocytes by desmosomes, but form a functional cluster called the epidermal melanin unit. In humans, roughly 1 melanocyte serves 36 surrounding keratinocytes.
We have two main types of melanin, which dictates our coloring.
Yes, the brownish-black eumelanin, which is highly protective against UV radiation, and the reddish-yellow pheomelanin. The genetic and environmental balance of these two dictates our skin, hair, and eye color.
Let's trace the chemistry of melanogenesis. Where and how is the pigment synthesized?
Synthesis occurs in melanosomes, which are lysosome-related organelles. The initial critical enzymatic step is catalyzed by tyrosinase.
What does that do?
It takes L-tyrosine to L-dopia, and then rapidly to L-dopaquinone. This intermediate then proceeds down one of two paths.
And that path depends on available chemistry.
It does. If the cell has sufficient cysteine available, the process favors the reddish-yellow pheomelanin. If cysteine is limited, the process tends toward the highly protective brownish-black eumelanin, which is also regulated by other enzymes like TRP1 and TRP2.
And the melanosomes themselves go through stages.
Correct. Stage I through 5. They mature from pre-melanosomes near the Golgi, gaining enzymatic activity, and then move along microtubules to the tips of the melanocyte processes as mature. Stage 4, melanin-filled organelles.
And here's a fascinating insight the text provides about pigmentation intensity. It's not just about the number of tyrosinase genes, but the environment of the melanosome.
That's the real nuance. Melanosomes in light skin are actually more acidic and display lower tyrosinase activity.
So the enzyme doesn't work as well.
Exactly. Conversely, melanosomes in dark skin maintain a more neutral pH, which allows the tyrosinase enzyme to function optimally, resulting in dramatically increased melanin production and intensity.
All without changing the gene expression levels.
Right. It's about the local environment.
Once synthesized, the pigment needs to get into the keratinocytes to perform its job. This process is called pigment donation.
The mechanism is called cytokine secretion. The keratinocytes actively phagocytose the tips of the melanocyte processes that are packed with melanosomes.
They just eat the tips.
They do. And once inside the keratinocyte, these melanosomes migrate and position themselves specifically above the cell nucleus.
Visually, what does this look like?
It forms the melanosome microparasol, or the dark umbrella, which you can visualize in Figure 15.10. It's perfectly placed to shield the nuclear DNA from damaging UV radiation.
thereby reducing the risk of mutations and skin cancer.
Precisely.
Now, a key point to reinforce. Skin color variation is not about the number of melanocytes. The number is constant across all ethnicities.
Correct. The variation is determined by the size, number, distribution, and most crucially, the rate of degradation of the melanosomes inside the keratinocytes.
So in darker skin.
In darker skin, the melanosomes are larger, more numerous, distributed individually throughout all epidermal layers, and they are degraded slowly. In lighter skin, they're smaller, often aggregated into clusters, and rapidly destroyed by lysosomal enzymes as the cells move toward the surface.
And the tanning response is a protective measure that kicks in due to UV stress. What is the molecular signal?
UV exposure damages keratinocyte DNA, which activates the p53 signaling pathway in those cells.
The keratinocytes themselves send the signal.
Yes, they then release various paracrine factors, including alpha, MSH, KITL, and FGF2, that bind to receptors on the melanocytes. This signaling cascade increases the expression of a factor called MITF, which accelerates melanogenesis and pigment donation.
And that's tan.
That rapid increase in the protective umbrella is what we recognize as a tan.
The source material stresses the importance of understanding these variations clinically, particularly using the Fitzpatrick phototyping scale.
That scale, ranging from I, always burns, never tans, to Xi, never burns, heavily pigmented, remains the standard classification system. It's highlighted because while melanin offers protection, skin cancer risk remains for everyone.
Right.
And melanoma diagnosis can often be delayed in individuals with darker skin because the lesions may not fit the classic visual profiles expected by clinicians used to treating lighter skin.
Let's quickly note the clinical correlations for melanocyte dysfunction.
Vitiligo is characterized by the acquired progressive loss of melanocytes, resulting in depigmented patches.
And albinism.
Albinism is a hereditary disorder where the individual has a normal count of melanocytes, but a defective pathway, most commonly a lack of functional tyrosinase, prevents melanin production.
But in the most aggressive pathology, malignant melanoma.
Melanoma originates from melanocytes. It's defined by its progression. It starts in the radial growth phase, where it spreads superficially within the epidermis, which usually has a low metastatic potential.
But then it gets dangerous.
It transitions to the highly dangerous vertical growth phase, where it invades the dermis as a nodule. This is when the cells often lose their pigment and readily metastasize to regional lymph nodes.
Making prognosis much worse. Early detection is everything.
It is.
Which is why we remember the ABCD rule for self-checking.
A for asymmetry, irregular B for border, multiple C for colors, and a D for diameter greater than 6 millimeters.
Next, the active security force, Langerhans cells.
These are the dedicated, antigen-presenting resident macrophages of the epidermis, making up about 2 to 5% of the total cell population.
And they're always on patrol.
They are. They're critical for immunosurveillance. They extend long dendritic processes through the tight junctions to sample antigens, even from the stratum corneum.
Once they capture something, what is their journey?
Upon processing the antigen, they leave the epidermis and migrate to the nearest draining lymph node. There, they instruct the adaptive immune system, either promoting tolerance or initiating a strong T-cell-mediated immune response.
Like an allergic reaction.
Exactly, like the delayed type hypersensitivity reaction we experience as contact allergic dermatitis.
Histologically, they are difficult to see in routine slides. What confirms their identity?
In H&E stains, they look similar to melanocytes, but using electron microscopy, you see their highly characteristic feature, the Burbeck granules.
What do those look like?
They look like tiny tennis rackets or stacked membranes.
What's in those granules?
The primary molecular component is langerin, CD207, a receptor. Burbeck granules function to internalize and degrade specific pathogens. The text specifically mentions HIV-1 and Candida albicans.
So they're part of our innate immunity.
Crucial to it. And a malignant proliferation of these cells is termed histiocytosis X.
The third and final specialized epidermal cell, Merkel cells.
Merkel cells are found in the stratum basal, often in clusters in areas of high sensory acuity like the fingertips. They are sensory receptors.
And their unique cellular feature.
They contain small, 80-nanometer dense core neurosecretory granules in their cytoplasm, hinting at their neural association.
Their function is entirely tied to the specialized structure they form.
That structure is the Merkel corpuscle. This is the association between the Merkel cell and the expanded terminal bulb of an afferent myelinated nerve fiber.
So it's a cell-nerve partnership.
It is. Together, they form a slow-adapting, highly sensitive mechanoreceptor. They translate mechanical pressure into a neural signal.
And clinically,
Unfortunately, they are also the cell of origin for Merkel cell carcinoma, MCC, a rare but extremely aggressive skin cancer.
we transition now to the dermal layer, the structural support. Let's start at the interface, the epidermal-dermal junction. It's not smooth, is it? It's highly interlocked.
It's an essential locking mechanism. The dermis projects upward into finger-like structures called dermal papillae.
And the epidermis grows down to meet them.
Exactly. They fit perfectly into complementary downward extensions of the epidermis called epidermal ridges or reweight ridges.
Why is that important?
This significantly increases the surface area for exchange of nutrients and, most importantly, provides maximum mechanical attachment, preventing the epidermis from being sheared off during stress.
And in some areas, this interlocking is so pronounced it dictates a physical macroscopic pattern.
That's the friction ridge skin, found only on the palms and soles. The pronounced corrugated surface of the skin, the actual ridges and furrows, is dictated by these highly organized, deep, interlocked ridges.
That's our fingerprints.
That's the basis of dermatoglyphics fingerprints, which are designed specifically to maximize friction for gripping and touch.
Within the dermis itself, we have two layers, defined by their connective tissue composition.
The superficial papillary layer and the deep reticular layer.
The papillary layer is the busy cellular zone.
It is. It's composed of loose connective tissue with fine type I and type 3 collagen. This layer is highly cellular and contains the capillary plexuses that nourish the epidermis, as well as many of the sensory nerve endings.
And the reticular layer is the bulk strength.
The reticular layer is thicker and characterized by dense, irregular connective tissue. It's less cellular, but packed with thick bundles of type I collagen and coarser elastic fibers. This is where the tensile strength of the skin comes from.
And those fibers have an organization to them?
They do. They're organized into regular lines of tension, critical for surgical consideration, the Langer lines or cleavage lines. Surgeons make incisions parallel to these lines because they follow the natural tension, which minimizes wound retraction and reduces scarring.
Let's discuss the key cells of the dermis, starting with the structural element.
The dermal fibroblasts are the main structural cells, responsible for synthesizing and remodeling all the ECM components, but they also have an immune function.
How so?
They express toll-like receptors, TLRs, which allow them to recognize pathogens and respond by initiating local immune responses and producing inflammatory cytokines.
Then we have the immune cells residing here.
Dermal dendritic cells, found mainly in the papillary layer, are highly effective antigen-presenting cells. Deeper in the dermis, we find resident dermal macrophages, which are long-lived and crucial for maintaining homeostasis and responding rapidly to damage.
And these macrophages are so long-lived and dedicated, they sometimes end up holding on to foreign material indefinitely. Which brings us to the tattoo mechanism.
This is a beautiful microscopic illustration of immune system persistence. When insoluble ink pigment is injected into the dermis, the resident dermal macrophages immediately recognize it as foreign material and attempt to phagocytize it.
They eat the ink.
They eat the ink. But critically, because the pigment is insoluble and inert, the macrophage cannot degrade it.
So the color we see is literally pigment trapped inside the immune cells.
Exactly. The pigment remains sequestered inside the cytoplasmic vacuoles of these long-lived macrophages. But macrophages do eventually die.
What happens to the ink then?
When a loaded macrophage dies, the ink is released into the extracellular matrix. This immediately triggers the immune system to recruit new macrophages, which promptly re-phagocytize the released pigment.
So a cycle.
This continuous process is called the ink capture-release-recapture cycle.
That cycle explains why tattoos age and blur.
Yes. The constant handoff from dying to new macrophages over years means the sharp edges of the initial tattoo gradually diffuse out, giving the tattoo that washed out or softened appearance.
And this cycle is why tattoo removal is so difficult even with advanced lasers.
It is. Laser treatment shatters the large ink particles and kills the macrophages holding them. But the fragmented pigment that is released is instantly recaptured by the new macrophages recruited to the injury site.
So the ink stays put.
The text suggests that future, more effective removal protocols might involve combining laser fragmentation with transient macrophage ablation, temporarily knocking out the macrophages to allow the lymphatic system to drain the fragments before they can be recaptured.
We also have a newly understood population of permanent immune cells here, the dermal T resident memory cells.
These are non-circulating memory T cells that take up permanent residence in the skin. They are generated after a previous infection or vaccination and provide rapid, robust immune surveillance.
They're like a permanent guard post.
Exactly. They lack the surface markers needed to leave the skin, ensuring the fastest possible immune response to pathogens that breach the barrier.
Finally, anchoring everything is the deepest layer, the hypodermis.
Also known as the subcutaneous fascia, this layer contains the panniculus adiposus, the layer of fat storage and insulation.
And it is associated with some specific musculature.
We have smooth muscle forming the erector pili muscles. These small muscles connect the deep hair follicle to the superficial dermis. When they contract, typically in response to cold or fright, they pull the hair shaft upright and create the phenomenon of goose flesh. And while most other striated muscle layers are vestigial in humans, they remain prominent in the face, forming the muscles of facial expression, like the platysma in the neck.
The skin's role as a sensory organ is facilitated by a dense and complex network of nerve endings. Let's explore how the skin registers the external world, starting with the simplest and most numerous endings.
That's the free nerve ending. These are the most common type of sensory receptor. They lack any protective capsule, and they terminate right up in the stratum granulosum.
And what do they sense?
They are responsible for registering pain, temperature, and fine, crude touch. They also form critical networks around the base of hair follicles, acting as highly sensitive mechanoreceptors for hair movement.
The second category are the complex, architecturally intricate receptors, the encapsulated nerve endings.
These are found primarily in the dermis and hypodermis, encased in a protective layer that often helps modulate the sensory input.
We'll start with the giant, which can be macroscopic, the Pacinian corpuscle.
Pacinian corpuscles are large ovoid receptors found deep in the dermis and hypodermis. They are classic receptors for deep pressure and high-frequency vibration.
What's their structure like?
Their structure is stunning. They look exactly like a cross-section of a cut onion. A single myelinated axon is surrounded by dozens of concentric cellular lamellae separated by fluid.
So pressure deforms the onion layers.
Right. The pressure of vibration physically displaces these lamellae, causing the resulting deformation to depolarize the axon. They are rapid adapters, meaning they sense the change in pressure, but stop firing if the pressure is sustained.
Next, the receptors for delicate, low-frequency touch, located high up in the dermal papillae, the Meissner corpuscle.
These are localized exclusively in the dermal papillae of hairless skin, such as the fingertips and lips. They are sensitive to light touch.
And their structure.
Structurally, they are elongated, tapered cylinders. Inside, unmyelinated nerve fibers twist and spiral, wrapped by flattened Schwann cells, resulting in a unique appearance often likened to a skein of wool.
And finally, the Ruffini corpuscles. What is their function?
The Ruffini corpuscles are the simplest encapsulated mechanoreceptors. Their primary job is to respond to sustained mechanical stress, skin stretch, and torque.
How do they do that?
Collagen fibers from the surrounding dermis pass right through the capsule. When the skin is stretched, those collagen fibers are displaced, which stimulates the axonal endings inside the corpuscle. They are crucial for sensing directional forces applied to the skin.
Moving on to the final major section, the specialized structures derived from the epidermis that perform distinct functions, the skin appendages. Let's start with hair follicles and hair.
The hair follicle is essentially an intricate, deep invagination of the epidermis. We divide it structurally into 4 regions: the infundibulum, the isthmus, the crucial follicular bulge, and the deep inferior segment culminating in the bulb.
The actual growth engine is the bulb at the base.
Yes, the base of the bulb is invaginated by the connective tissue of the dermal papilla, which contains the blood supply. Surrounding this papilla are the hair matrix cells.
And they're the ones doing all the work.
They are. These are extremely rapidly dividing and differentiating stem cell progeny, migrating downward from the follicular bulge, and they are responsible for synthesizing the hair shaft. This is also where melanocytes donate pigment to the developing hair cells.
The text highlights the critical importance of the epidermal stem cells, ES niche. Where is it and what does it do?
The primary ES niche is located in the follicular bulge, right near where the erector pili muscle inserts. Normally, these ES cells migrate downward to feed the hair matrix, sustaining hair growth.
But they have a dual role.
They do. In the event of severe epidermal injury, like a second-degree burn, these stem cells are triggered to migrate upward to resurface and repair the damaged epidermis. The follicle is thus a vital reservoir for skin regeneration.
The hair shaft itself has distinct layers, composed of hard keratin.
Unlike the soft keratin of the epidermis, hair is made of highly cross-linked hard keratin. It has 3 layers: the central medulla, the substantial cortex making up 80% of the hair mass, and the outermost cuticle of overlapping cells.
And surrounding the hair shaft are the protective sheaths.
The internal root sheath, IRS, is transient. It breaks down and disappears at the level of the isthmus. The external root sheath, ERS, is continuous with the epidermis. The whole assembly is separated from the dermis by a thick basal lamina called the glassy membrane.
The functional correlation regarding hair growth emphasizes that growth is cyclic, not continuous.
Hair growth follows a precise cycle. Anagen, the active growth phase, which determines hair length, catagen, a brief regression phase, and telogen, the resting phase.
And then the hair falls out.
During telogen, the follicle shrinks and the hair shaft detaches, becoming a club hair that is eventually lost.
And what determines hair graying?
Graying is fundamentally linked to the programmed apoptosis of the melanocyte stem cells within the hair matrix. Genes like BCL2 and MITF are involved. As these stem cells are depleted, the hair matrix can no longer receive pigment, leading to the growth of colorless or gray hair.
Let's move to nails.
Nails are specularized epidermal structures, defined as plates of hard keratinized cells that protect the distal phalanges.
Where does the growth originate?
Growth is entirely due to the nail matrix, the germinative zone located beneath the proximal skin fold, the nail root. Stem cells in the matrix divide and differentiate into hard keratin.
And the process is different from the skin.
It is. The process of keratinization here does not involve keratohyalin granules, which differentiates it from epidermal keratinization.
Let's define the key parts.
We have the nail plate, the underlying nail bed, the buried nail root, and the white crescent-shaped area called the lunula, which is the visible part in the matrix. The skin fold is the eponychium cuticle, and the skin securing the free edge is the hyponychium.
Next, the oil glands, sebaceous glands.
These are generally multilobular glands, usually associated with hair follicles, forming the pilosebaceous units. They secrete sebum, an oily mixture of triglycerides, wax esters, and squalene.
And the method of their secretion is highly distinctive, known as holocrine secretion.
Holocrine is a destructive form of secretion. The entire secretory cell, the sebacyte, fills up completely with the lipid product. It then undergoes programmed cell death, apoptosis, and the entire dead cell product, and all is discharged as the secretion.
And new cells replace it.
Continuously. New cells are generated by basal cell mitosis at the periphery of the gland, with a turnover time of about 8 days.
Sebum production is tied to development and hormones.
Activity is minimal before puberty, but surges afterward, primarily regulated by androgens.
And when the system goes wrong, it leads to acne vulgaris.
Acne is a chronic inflammatory disease caused by 3 factors: seborrhea, excessive sebum, abnormal follicular keratinization that blocks the exit canal, and the resulting proliferation of the Propionibacterium acnes within the blocked unit.
Which leads to inflammation.
Exactly, inflammation and abscesses.
Finally, the sweat glands. We have 2 distinct types.
The most widespread are the eccrine sweat glands. They are simple coiled tubular glands found nearly everywhere and are independent of hair follicles.
What is their primary function?
Their major indispensable role is thermoregulation via evaporative cooling. Their secretion is a hypotonic, low-protein ultrafiltrate of blood.
And histologically, their secretory segment is complex.
It is. It contains 3 cell types: clear cells for the watery component, dark cells for the protein component, and surrounding myoepithelial cells, which contract to squeeze the product out.
And their control system is unusual.
Thermoregulatory sweating is driven by cholinergic sympathetic fibers using acetylcholine, which is an exception to the normal sympathetic rule. However, emotional sweating is typically mediated by the normal adrenergic sympathetic system.
The second type is highly restricted, the apocrine sweat glands.
These are large lumen glands restricted to specific areas like the axilla, areolae, and perineum. They're associated with hair follicles and only become functional after puberty.
How do they differ histologically and chemically?
They have a very wide lumen for storing secretion and a simple epithelium of one secretory cell type. Although they were historically thought to use apocrine secretion, modern analysis confirms they use merocrine secretion.
And their product is different.
It is protein and lipid-rich, and it is initially odorless.
But it quickly develops an odor.
Yes. The characteristic acrid odor develops due to bacterial action on the organic compounds once they reach the skin surface. These secretions are thought to contain pheromones.
Let's connect sweating to specific diseases in the clinical correlation.
Elevated concentrations of sodium and chloride in sweat are the key diagnostic indicator for cystic fibrosis. Separately, in advanced kidney failure, or uremia, the body excretes excess urea through sweat, leading to visible crystal deposits known as urea frost.
And excessive sweating.
That's hyperhidrosis, which is pathological, excessive sweating, often unrelated to thermoregulatory demands.
The skin is a champion of self-repair. The text describes healing based on the nature of the wound, primary union and secondary union.
Primary union, or first intention, happens in clean wounds where the edges are brought together, like a surgical incision. Healing is fast, scarring is minimal.
And secondary union.
Secondary union, or second intention, occurs in severe wounds with significant tissue loss. This requires the formation of extensive granulation tissue to fill the gap, resulting in more pronounced scarring.
How does the surface epithelium repair itself, reepithelialization?
After a scab forms, the basal keratinocytes at the wound margin rapidly activate. They proliferate and begin migrating as a thin sheet underneath the scab until they meet, restoring the multi-layered epithelium.
And the importance of the appendages returns in severe wounds.
In deep wounds, like second-degree burns, the epidermal stem cells, ES cells, residing in the follicular bulge, become the crucial source. They migrate upward from their deep, protected niche to facilitate rapid resurfacing.
So without them, you need a graft.
Without those stem cells, such as after a third-degree burn that destroys the entire follicle, grafting becomes necessary.
Let's wrap up with the inevitable, skin aging. This decline is multifaceted, driven by environment, genetics, and metabolic wear and tear.
The structural and functional losses are widespread. In the epidermis, we see keratinocyte atrophy, leading to overall thinning. The dermal-epidermal junction flattens out, which makes older skin far more susceptible to blistering and shearing injury,
And dryness.
and increased transepidermal water loss, resulting in chronic dryness.
The skin's immune function also takes a hit.
Absolutely. The phagocytic system declines. The numbers and migratory capacity of Langerhans cells drop, and the efficiency of dermal dendritic cells decreases. This contributes to the increased rate of skin infections seen in elderly populations.
And what happens to the dermal structure that provides strength?
The dermal fibroblasts shrink and reduce their synthesis of new collagen. Critically, they start expressing higher levels of matrix metalloproteinases, MMPs.
The enzymes that break things down.
Exactly. They actively fragment and degrade the existing collagen and elastic fibers. This fragmentation leads to reduced elasticity, loss of resilience, and the characteristic wrinkling of aged skin.
And finally, the glands decline.
Reduced sweat and sebaceous gland secretion, which exacerbates dryness and weakens the antimicrobial barrier. Even the hypodermis often experiences subcutaneous adipose tissue reduction, contributing to the loss of padding and structure.
So what does this all mean? Our deep dive reveals that the integumentary system is not just a passive wrapping, it is a meticulously managed frontier.
It really is. Its entire function relies on an exquisite 47-day chemical clock governing epidermal renewal, all sustained by that complex water barrier, the mechanical lyricrin shell, waterproofed by the ceramide lipid envelope.
And here's where it gets really interesting, connecting the microscopic detail to the big picture. We detailed that pH gradient, the precise chemical balance that dictates when the KLK enzymes activate to shed cells.
Right.
So we're saying the acidity of our skin literally decides when our cells die and shed. That's an incredibly precise biochemical clock.
The level of environmental sensitivity is astonishing.
It is. So given this constant, delicate balance, consider this. How might our chronic internal states, our stress levels, our diet, or subtle ongoing microinflammation perpetually throw off that pH gradient or accelerate the MMPs in the dermis? It suggests that the aging and repair of our skin is not a fixed, linear process, but rather a system perpetually being challenged and reshaped by internal chemistry, forcing it into constant, accelerated repair mode.
A complex system built on delicate balances that are constantly fighting external and internal pressures. A fascinating thought to mull over every time you look in the mirror. Thank you for joining us for this extensive deep dive into the integumentary system.